So cross-linking in a busy practice. So, one of the things is to understand the science. And then the second step is how do you actually do it on a daily basis? And so here are my financial disclosures, both CorneaGen and Avidro. And we'd already talked through the indications for cross-linking. And like Dick said, you should know them. So here's the first step. The patient is diagnosed with keratoconus by somebody. Most of the time, that's not the cornea specialist. In our region, that's almost always the optometrist. Occasionally, it's a comprehensive ophthalmologist. And then they come in to see you, and you look and see if they do indeed have keratoconus and if you can document progression or not. And then you talk through the options with the patient. And really, there's not an alternative option that makes sense that can slow the progression of keratoconus. We used to have this really big gap, right? It was, we're going to give you a scleral contact lens, or we're going to do a cornea transplant. And there wasn't anything in between those two places. And now the only thing that is in between those places is crosslink, and thank goodness that we do have it. So the conversation that I have with the patient and setting expectations is, look, you've got keratoconus. Keratoconus is a disease where your cornea is floppy. And that floppy cornea has a tendency to bow and become cone-shaped. And then when light comes through, it's scattered and you can't see as well. Now, part of this is because of your genetics, most likely, but a big part of it is because you rub your eyes. And they say, I don't rub my eyes. And I say, do you rub your eyes? And then I look at the spouse. And the patient says no, and the spouse says yes. And then, no kidding, this is what I tell them. I say, listen, you have to stop rubbing your eyes or we're going to have to do an arm amputation. And then... and then they get how serious it is to actually stop rubbing their eyes. And so and then I turn to the spouse, and if it's a male patient, I say, you now need to nag him every single time that he rubs his eyes. You have to give up nagging about something else, but you are instructed to nag about rubbing your eyes. And it's really important because then I tell them, if you keep rubbing your eyes, you will win this battle no matter what I do. Whether I do a cornea transplant or I do cross-linking, if you keep rubbing your eyes, you will win and your eyes will suffer for it. And then I talk to them about the good news. And the good news is, if you stop rubbing your eyes and we do cross-linking, I think that there's a very high likelihood that we can prevent a cornea transplant in you, and you don't want to have a cornea transplant. And then we say that insurance coverage has improved dramatically over the last few years, and almost always this is covered by insurance. And that's the beginning of the conversation. Now, because keratoconus is a progressive disease, we want to catch it early and lock it in place. Now, the labeling for it is progressive keratoconus. Now, most people that are young and have keratoconus are going to have progressive keratoconus, and there's a number of different ways that progression can be documented, whether that's refraction or Kmax or something that changes on a pentacam or a different place. Now, slit lamp exam findings are late in the disease, so you really need to have a topographer to be good at diagnosing keratoconus early. And you also have to be really good at educating your referring network. And we'll talk about that in just a second, because that's where the patients are at. So we were lucky enough to participate in the cross-linking trials. And so for 8 years, we've been educating the entire state of South Dakota, referral base on what the value and the importance of keratoconus screening is. And what I really tell them is, if their glasses are changing, ask the patient, ask the mother if the person is rubbing their eyes. And if they are, tell them to stop and send them in for screening. And that's how we identify these patients that have keratoconus early. We've also done, some social media and outreach, but I don't really think of this as trying to drive our business in any way. What I want to know that 15-year-old kid somewhere that has keratoconus that nobody's thinking about it actually gets picked up so that they don't progress to the point of no return and ultimately need a cornea transplant. So what are the workflow considerations as you think about this? This is not exorbitantly difficult to implement in your practice. The biggest challenge is that patient's there for an hour-long treatment, and most of our treatments are longer than that, okay? So you need to have a place where the patient can lie down. You need to understand that it's going to take up a bunch of your tech and a bunch of your nurse time during the day. And then for equipment, almost all of us are going to have a topographer. Ideally, if you can have something that images the posterior cornea, that's better. We also use corneal hysteresis. That helps us understand if that's a floppy cornea, and that's been really helpful for us too in determining some borderline cases on what we want to do. And then so the day of surgery, you want to make sure that the medications are there. You set up all of their treatments. And then different practices do it differently, but that patient's going to be there that day for an hour to maybe an hour and a half, because remember, you're soaking the cornea for 30 minutes with the riboflavin and you're delivering 30 minutes worth of light. So the minimum amount of time they're going to be there is 1 hour. And in some places, the doctors do the entire thing, and in other places, staff supports that. So what does the follow-up look like? Well, at day one, they're on a topical antibiotic, a steroid, and an NSAID. We usually do something like 4 times a day for a week, and then decrease it to twice a day for a week, and then stop from there. We happen to use compounded combination medications. Frequent lubrication. This feels like PTK or PRK, maybe even a little bit tougher because you've shined that UV light, and it's maybe a little bit more pro-inflammatory than just a PRK or a PTK is. At 1 week, they can probably come off of their antibiotic. And every single time we remind them no eye rubbing. And it's really fascinating. If you talk to your keratoconus patients about eye rubbing, they find it very oddly pleasurable. I mean, they really get those knuckles in there. And Alan Carlson has really great videos of what these patients want to do. And sometimes I'll ask them to rub their eyes in front of me, and it's just shocking. And then I say, that is the single last time that you're ever going to do this. At month 1, you can get some OCT imaging of the anterior segment. That's really to see a demarcation line. You really don't change any treatments based on that, so we don't do it on a routine basis. You could get a topography or a tomography, but I don't do that either at 1 month because we know they're still in evolution. I'm, again, not going to change anything based on it. You can start to put these patients in contact lenses. The cornea is going to continue to remodel for 6 months, 12 months, maybe even up to a year, slowing down over time. Some doctor, and we had this debate in our practice, some doctors say, when am I going to put that contact lens back on? Their eye's still changing at 3 months. Yeah, you could wait till 6 months, or you could wait till a year, but how much is 3 months worth of vision worth, or 1 month worth of vision worth? So we just have that conversation with the patient that we think that you need a new contact lens or a new pair of glasses, but know that you're probably going to change them in 3 months. And they're happy to see, they're not bummed that they have to change their glasses or contact lenses in 3 months. And then we just watch from there. Insurance coverage. This used to be the worst part of my day. And 2 years ago, I spent a lot of time on the phone with medical directors from insurance companies arguing for why this should get reimbursed. And now the coverage is really good, and I spend very little time. But if you are running into an insurance reimbursement issue, the folks from Avedro will help. But my tactic was that I always had all the peer-reviewed literature in PDFs in an email, and I'd send the medical director of an insurance company all, 50 papers on why cross-linking is effective. And then I'd set up a phone call, and I'd ask him if he read all of them. And then I'd say, and then he wouldn't say anything, or she wouldn't say anything. And I'd say, so wait a second, you're going to not read the literature. You're going to deny the patient that I'm looking in the eye, the treatment that we all know is effective, without even reading all of those papers? How about we have a call in a week after you've read them? And then we'd get an email back later saying it's approved. And so it's a very effective strategy. The other strategy is to enlist the patient and have them rattle the cage too. And we would work hard on it. And it was work, but it was work that was worth it, because now our patients actually get the coverage that they need. There is something from Avedro called the ARCH program. And I want to, just a little tip of the hat to Avedro. They have worked really hard to get patients that don't have good insurance coverage access to this care, because they know these patients need it. And so reach out to them through the ARCH program, and there's ability to get free and reduced price drug for people that can't pay for it, and they'll make sure that that's all done in a compliant way. We usually get a pre-authorization, but we've gotten pretty good at it now since we've done so much of it. Couple of pearls. Join in the patient with the fight against their progression of the disease and celebrate that with them. And so many patients, and a lot of times these are younger patients that we as cornea specialists might not see a little bit. You really get to celebrate with a family when they thought that they were headed to a cornea transplant and now they don't have to undergo that. Diagnose and treat early, work with your referral network. Setting patient expectations isn't too difficult. It just says, hey, this isn't intended to make your vision better. What this is intended to do is stop you from needing a cornea transplant and stop your keratoconus from progressing. And it's really a rewarding thing to do. Thank you guys so much.